Okay, awesome. So the case today is 6 aliquots, and the sixth one reveals the final diagnosis. So aliquot one, we have a 59-year-old male with a history of hypertension and prior tobacco use, who comes in with 4 weeks of progressively worsening shortness of breath, lower extremity swelling, and 10 pounds of weight gain. And that's the end of the first aliquot.
All right. Thank you so much. Already an internist, a dream complaints to focus on. Um, so we're starting with the 59-year-old male who's coming in with kind of progressive, kind of like acute to subacute shortness of breath, weight gain, and lower extremity edema. I'll just focus on the shortness of breath and then ask Jack to layer on the other factors. Shortness of breath is one of those dyspnea, is one of those complaints that is as broad as it gets, right? Thinking about dyspnea, one of the things that I try to initially get a good sense is that if there's any like hypoxemia associated with it, because hypoxemia itself narrows your differential for shortness of breath. Because dyspnea could be anything from like generalized weakness, people can get more dyspneic. Anemia can people make more dyspneic. Like any systemic illness or chronic illness can have a certain degree of shortness of breath due to fatigue, due to like the illness itself, due to deconditioning, present with shortness of breath. The most of the money for us is when it's accompanied with hypoxemia, and that puts the center of gravity towards the lung and the cardiovascular system. And when it comes to dyspnea alone, whenever I'm evaluating any patients, at first, my concern is like, what is my no misdiagnosis here? And for dyspnea, it becomes like the pulmonary and cardiovascular system. So like an acute onset heart failure, cardiogenic shock, pulmonary embolism, tension pneumothorax, things that can need to be urgently evaluated are usually tend to be my no misdiagnoses. So I'll stop there and then pass along to Jack to layer on the other symptoms.
Yeah, right on. So, if we sort of start to filter in the weight gain and the lower extremity edema here, and sort of say the weight gain can come from both accumulation of solids on the body, like adipose tissue, or more often than not, water on the body. And I think the presence of edema makes it likely that this is water weight that this gentleman has started to retain. There's three primary organ systems that can lead to the development of fluid retention, and that's going to be the heart, the liver, and the kidneys. And that's the order with which they are likely to present with shortness of breath alongside the lower extremity edema and the weight gain, right? Most commonly, we see CHF leading to a syndrome of exactly this: progressive dyspnea, lower extremity edema, and weight gain. But the liver can lead to weight gain and shortness of breath via ascites, lower extremity edema from volume retention. And then individuals with cirrhosis can develop shortness of breath primarily from the accumulation of ascites that leads to reduced diaphragmatic excursion. Renal disease can, in its later stages, can lead to the development of shortness of breath and edema through, again, volume retention, but then also through the development of anemia from low EPO production. So at this point in time, like Sharmin was saying, right, shortness of breath and the presence of fluid retention and the absence of inflammatory features puts a cardiac disease at the forefront of our minds. But if that hypothesis loses momentum as things unfold, right, we don't see an elevated JVP, we don't see pulmonary edema, then we still have other ways to explain these symptoms through looking for hepatic disease and then fairly progressed renal disease at this point in time.
Awesome. Am I good to go with aliquot two? Awesome. So for aliquot two, he previously describes himself as a healthy and active person, running an average of 10 to 15 miles a week with his friends. And then 4 weeks prior to presentation, he had 2 days of what he describes as a cold. During that episode, he had 2 nights of drenching night sweats and was out of work for a few days because he felt so horrible. He figured he had COVID, but didn't test himself at home. And then initially felt like those symptoms got better, but over the next 2 weeks, noticed that when he tried to run, he couldn't keep up with his friends anymore. So he decided to go to the emergency room to get it checked out. At the outside hospital emergency room, his vitals were normal, including a normal SpO2. His labs were only notable for a troponin T that was mildly elevated to 77, but flat at like 74, a BNP that was mildly elevated to 120, and an EKG showed 2-to-1 atrial flutter with no ST changes. A CTPE was done at that time, which showed no pulmonary embolism, but a small complex appearing pericardial effusion with some concern for underlying pericarditis. And an echo was done showing an EF of 55%, and then also a small pericardial effusion with echogenic material. He was discharged at that time on DIL and metope for his aflutter, and then started on colchicine due to the concern for pericarditis. But ultimately, his symptoms never got better. And after leaving the emergency room, he then started to develop worsening dyspnea on exertion, new lower extremity edema, orthopnea, and 10 pounds of weight gain. That was why he presents to the ED this visit. A review of systems is otherwise negative for cough, fever, chills, a runny nose, sore throat, chest pain, abdominal pain, diarrhea, constipation, or rashes. And then just briefly, his medical history is notable for well-controlled hypertension, surgical history. He had a prior umbilical hernia repair in 2018 that was uncomplicated. Meds, he's only on lisinopril hydrochlorothiazide. His family history is non-contributory. And then his social history is notable for 17 prior tobacco use, 17 years, quit 6 months ago. And then he drinks 2 beers a week on average and works as a florist. He has no recent travel or animal exposure. And that's the end of aliquot 2.
All right, this gets richer and richer with every sentence you share. I think I'll spend a little bit of time just sort of talking about a general way that we can think through this clinical problem, and then leave some of the details in terms of the atrial flutter, the response to DILT, and some of these other features to Sharmin. But I think if we look at this case, right, we said at the beginning, the leading diagnosis here, just from the one-liner, is that this is a syndrome of CHF. And I think what I'm starting to ask myself is, okay, how well is the information that Luca is continuing to give us mapping onto a characteristic CHF illness script? There are some things that fit with this, right? The progressive edema, the orthopnea, the progressive weight gain, and the reduced exercise tolerance. But there's a couple features that don't necessarily map on well to our characteristic CHF trajectory. One of those things is the tempo of the illness. And the other thing is some of the data that we had from the initial evaluation in the emergency room. If you all think about cases of CHF that you've seen over time, more often than not, these are diseases that progress over usually months, right? Where there is a preceding period of decreased activity, then the development of mild symptoms, then maybe moderate to severe symptoms that bring someone into the hospital. But this is somebody who went from running 10 miles a day to having really no exercise tolerance over the course of days to weeks. And I think when we see hyperacute heart failure like that, we have to be aware of the possibility that this is not our typical run-of-the-mill heart failure, right? The most common causes of sort of run-of-the-mill heart failure are going to be ischemic cardiomyopathy and non-ischemic pathology, whether that's related to underlying hypertension or valvular disease, for example, or arrhythmias, right? That sort of is our general framework. But then we can start to bring in alternative pathologies when we get into hyperacute heart failure. If we then bring in the finding of the mildly elevated troponin on the evaluation in the ER, combined with a recent viral illness, right? We can think through the troponin elevation in another structured framework. Troponin elevations can be from myocardial ischemia, which could be from plaque rupture events or demand, or they can be from myocardial injury, which can be from something like a myocarditis or infiltrative diseases of the myocardium. This is somebody who has maybe some risk factors for atherosclerotic coronary artery disease. And so maybe we would say, oh, this is just a demand ischemia and descending of new heart failure. But the flat troponin over the course of his time in the emergency room makes the probability of a smoldering myocardial injury a little bit more likely here. And so while we would still say most likely this is a demand ischemia, there's some points being accumulated in the column for myocarditis, right? A post-viral cardiac disease characterized by a flat troponin elevation and a pericardial effusion begins to invoke not just the diagnosis of pericarditis, but actually the diagnosis of myopericarditis. Because normally pericarditis, we shouldn't see troponin elevations unless there's a demand ischemia or the myocardium is involved from an inflammatory process. And so I think the jury is still out on whether this is just a characteristic run-of-the-mill CHF exacerbation, or we are indeed in the hyperacute heart failure framework, of which myocarditis is one of the underlying pathologies. And I think as time goes on, we'll have to ask ourselves, how much is this looking like characteristic CHF and how much is this looking like myocarditis? But I think certainly with that troponin elevation and the pericardial findings, we're making more and more of a case with each aliquot that the reason for this aggressive CHF progression might be related to underlying myocarditis.
Our fire alarm is going on. Jack, do you want to keep going? This should turn off. Sorry.
I'm happy to keep going. All right. And so
I think my apartment is very concerned about this patient.
So then we have to say, okay, well, is there anything else that happened to this patient that could have accelerated this progression, right? Because we're saying that one of the reasons that it could have progressed over weeks is because the disease is very aggressive. But another reason that it could have progressed very rapidly is because we did something to this patient. And there's one thing that that stands out to me in terms of some of the medications that he received that might be a reason for an accelerated reduction in cardiac function. If we look at one of the meds he got, which is diltiazem, we can go back to our pharmacology lectures and remind ourselves that diltiazem is one of the non-dihydropyridine calcium channel blockers. And the way that diltiazem works is it's a calcium channel blocker, which is going to reduce the amount of calcium influx into cells, particularly in the myocardium. And much more so than beta blockers, diltiazem and the other non-dihydropyridine calcium channel blocker, verapamil, they can have a big impact on ejection fraction. They're actually contraindicated in individuals who have heart failure with reduced ejection fraction. And so if we ask ourselves, well, gosh, could diltiazem be a possible explanation for the acceleration of symptoms? I think the answer is yes, right? I suspect that this gentleman came into the ER with some reduction in EF, just given how active and vigorous he was. That EF of 50 to 55%, I think is what it was, is probably not his baseline EF. And so maybe his EF was falling because of the possible underlying myopericarditis. And then the diltiazem just accelerated that reduction in his ejection fraction. But I think as we move forward, what we're going to have to be attuned to is looking for signals, one, to confirm the CHF hypothesis, but also to really try to solidify the myopericarditis hypothesis. Certainly, the pericardial disease makes that much more likely, but then we also are going to want to falsify the more common diagnoses, right? Maybe we need to look at his coronaries. We'll look for a background of hypertension, right? Maybe if we control his arrhythmia, things improve. And if they don't improve, it makes it unlikely that the arrhythmia is driving his heart failure. But those four common buckets, ischemia, hypertension, valvular disease, and arrhythmias, need to be falsified before we start to entertain the more esoteric diagnoses of myocarditis. Although, again, there is a signal building for that from the information Luke gave us here. All right, Luke, go ahead and take us forward.
Awesome. So for aliquot 3, when he comes to our emergency room, his vitals are temp 97, heart rate 103, blood pressure 108/80, respiratory rate 18, and then satting 96%, now on 3 liters nasal cannula. On exam, he's in no acute distress. His cardiac exam, he has no murmurs, rubs, or gallops, but his tachycardic and his heart sounds are slightly decreased. His JVP is at 9 centimeters and increases to 11 centimeters on inspiration. He has bilaterally decreased breath sounds, worse at the bases, and then 2+ pitting edema to the tibial plateaus bilaterally with no clubbing or cyanosis. And then his extremities are warm on exam. For labs, his white count is 15.6. With 87% neutrophils, 5% lymphocytes, and 7% monocytes. His hemoglobin's 14.7, and platelets are 338. His sodium's 132, K is 4.2, calcium is 8.4, and creatinine is 1.99 from a baseline of around 0.7. His AST, ALT, and alk phos are all within normal limits. And then his VBG, VBG is done notable for a pH of 7.4, a CO2 of 36, and a lactate of 6.0. His troponin T is 66, so stable from kind of the prior hospitalization. And his BMP is now 426. A TSH is within normal limits, and A1C is 6.1. Lipids are normal. And then a UA is done given the creatinine and is just notable for 30 protein, but negative for leukocyte esterases, nitrates, blood, or glucose. And then last thing, his EKG is again showing 2-to-1 atrial flutter with no ST changes, so unchanged from prior. And his chest X-ray shows large pleural effusions, right greater than left. Let me know if you need to repeat any of that.
No, that was thank you so much for that. So I think there's a few different layers of this that we can study at this point in time, right? One of the things that we can study, sorry about that. One of the things that we can study is the severity of this CHF exacerbation. And if we look at just the exam alone, there's even though his extremities are warm, there's some clues that indeed this gentleman's ejection fraction may be severely reduced, and that he may be on the precipice of tipping over into a very significant cardiogenic shock, right? So if we look at the vital signs, I think somebody mentioned in the chat already. I see Monty saying this is not ideal. John's a nervous wreck, and is also highlighting the sinus tachycardia here. And I agree with you all, right? If we go back to our cardiac hemodynamics, right? Cardiac output is a product of heart rate and stroke volume. This gentleman's heart is doing its very, very best to maintain a normal cardiac output. And it's doing that by augmenting sympathetic tone to drive a sinus tachycardia because the stroke volume has likely fallen dramatically in the setting of this myocardial dysfunction. We see other evidence of that if we study the blood pressure and see that his pulse pressure is actually quite narrow, right? Most people have a pulse pressure anywhere from 30 to 40 and sometimes higher as they get older and their blood vessels get stiff. But this gentleman's pulse pressure has fallen down into the 20s. And this is somebody who probably has a very robust myocardium from the amount of exercise he does. So that narrowing pulse pressure, sinus tachycardia, and a physical exam consistent with CHF suggests not just a CHF exacerbation, but potentially impending cardiogenic shock just from the exam alone. And if we turn our attention to the labs, right, we see that is indeed confirmed with the lactate of 6, right? This gentleman is struggling to perfuse his organs effectively, maybe hanging on okay for now, right? We don't see other things like a congestive hepatopathy or terrible renal function, but I wouldn't be surprised if this is a bit of an AKI from his baseline as well. So if we just look at the general picture here, right, this is somebody who may be tipping further and further over into decompensated heart failure and may need more aggressive intervention. Right? We have our usual things, diuresis and afterload reduction, and in this case, stopping his diltiazem. But then we also have our ancillary therapies, which may involve things like inotropes, like dobutamine and or pressors to support him through that. And this is somebody who may be heading in that direction from a management perspective. Alongside that management, right, we have to ask ourselves, well, what is the etiology of this? And again, we have those 4 common causes of CHF: hypertension, arrhythmias, valvular disease, and ischemia. But some of those things are seeming less and less likely over time here as we look through both his background history and the tempo of development here. There's some other things about the labs that maybe turn our attention into there being something else other than run-of-the-mill CHF happening, which is the fact that there's a leukocytosis that's present here. Right? Most CHF exacerbations are not inflammatory in nature. Some people who have known heart failure can tip over in the setting of an acute infection, but the combination of new heart failure plus signs of systemic inflammation on the labs, again, add credence to the hypothesis that what we're dealing with is possibly a myopericarditis. And so if we start to ask ourselves, well, can we build a framework for thinking about potential causes of myopericarditis? The general categories that we'll think about is myocarditis secondary to a recent infection. For example, that could be COVID, other URIs like the flu, and then some atypical GI bugs, for example, can be a part of that. But then there's also some primary myocarditis syndromes like giant cell myocarditis and eosinophilic myocarditis, right? And even though there's an absence of eosinophils on the peripheral smear here, there still is the possibility of eosinophilic myocarditis in the myocardium as well. Similar to acute eosinophilic pneumonia and chronic eosinophilic pneumonia, which can have variable peripheral levels of eosinophilic myocarditis may also have variable peripheral eosinophilia. And so we can start to think about potentially, as we manage this gentleman, ways that we may get more data about those different categories of myopericarditis here. We may end up talking more about them, or we may discover one of the common etiologies of heart failure that we talked about as well.
Awesome. I'm glad that other people are stressed. I was very stressed as an intern, and still am. For aliquot 4, his pleural effusions are drained next due to the subjective shortness of breath and the new O2 requirements. So I'll give you the data from the pleural effusion studies. So his LDH in the fluid was 1,822, and in the serum was 744. His protein is 2.2 in the fluid, and then serum protein is 4.7. The pH is 7.6, and glucose is 16, and a gram stain is negative. A repeat echo is done, again showing an EF of 50 to 55%, with a slightly elevated right atrial pressure, and then a small pericardial fluid effusion, which appears smaller than the 3 weeks ago, but slightly decreased RV function. And then both the RV wall and pericardium also now appear thickened. He ultimately has a right heart cath done due to concern, exactly like you were saying, that he was in shock. And I'll give you some of the numbers from the right heart cath. So his CVP is 15. His mean pulmonary artery pressure is 24. His wedge is 17. And his SVR is 1800. And SVO2 is 48%. And then his CI is 1.5. And then there's a note in the right heart cath report that says there is evidence of discordance on end inspiratory beats, not clearly evident throughout the inspiratory cycle, with concern for constrictive physiology. And then, as you kind of were alluding to, he was transferred to the cardiac ICU, given his CI of 1.5. And I'll stop there.
All right. This case just gets better and better. Luke, thank you so much for bringing this over to us. So just to sort of summarize this, and because it's always high risk to do math in real time in front of an audience, I just want to make sure that I'm clocking this right, which is that seems that we have actually exudative pleural effusions from his pleural fluid, as well as findings of ongoing mildly reduced ejection fraction, and then possibly constrictive physiology that he has developed based off of his cath findings. Is that a fair summary? Great. So we can start here by just saying the fact that there is an exudative pleural effusion in the setting of new heart failure moves us into the category of some of the more esoteric or inflammatory diseases associated with CHF. Most pleural effusions in heart failure are going to be transudative in nature. Occasionally, long-standing effusions can turn exudative over time, but this gentleman has a new heart failure syndrome, and those pleural effusions are also likely new. So the exudative nature of this is quite unique. The findings on cath tell us that indeed the pericardial inflammation and the pericardial process is leading to pretty impressive hemodynamic changes for this gentleman in terms of the form of constrictive pericarditis, or I should say in the form of pericardial constriction, which would be compatible with constrictive pericarditis. Constrictive pericarditis can arise from a variety of reasons. The most common is a late complication of pericarditis, right? The chronic inflammation within the pericardial tissues leads to the development of basically fibrin and fibrous tissue in the pericardium. That fibrous tissue can become thick and stiff and start to scar, and individuals can ultimately end up developing a basic constriction within the pericardium. There's a couple other causes of constrictive pericarditis that we can go through and just sort of and just sort of ask ourselves which of these could be going on here. We can think about it in the lens of non-inflammatory causes of constrictive pericarditis and inflammatory causes of constrictive pericarditis. And the inflammatory or the non-inflammatory causes are basically related to any sort of recent myocardial injury. The most common is going to be after cardiac surgery or after a myocardial infarction. And then there's some other causes of non-inflammatory constrictive pericarditis that we can see. But in this case, right, we have features of an inflammatory disease, right? We have a high white blood cell count and an exudative pleural effusion within the pleural fluid. So we can run through the potential causes of constrictive pericarditis that are related to inflammatory diseases. Within the infectious category, TB is probably the most common one in individuals who are exposed to TB endemically. That is usually going to be a smoldering disease that progresses slowly over time. And there's usually some signature of TB elsewhere in the body, whether that's prior granulomas in the lungs, active cavitary lesions, or signs of dissemination like lymphadenopathy or involvement of the reticuloendothelial system. There are certain cancers that can do it, particularly carcinoid tumor is one of the tumors that can lead to the development of constrictive pericarditis. And then there's a variety of different underlying autoimmune diseases that can do it. For example, there's seropositive autoimmune diseases, lupus, RA, and EGPA. And then there's some seronegative diseases, for example, like IgG4 disease that can have features of constrictive pericarditis. So if we take that whole bucket together and ask ourselves, well, how might this have developed? One way to spin this is that this gentleman had a recent viral syndrome that led to pericarditis, and then that pericarditis has involved the myocardium and restrictive physiology within the pericardium. But I think we have to be open to the possibility of the other inflammatory myocardial diseases like giant cell or I think less likely eosinophilic myocarditis at this point. And then some of those autoimmune diseases can certainly do it, right? Whether that's sarcoid, which can have a myocarditis, or the other autoimmune diseases that we just talked about, they are all on the table. One interesting feature of this gentleman's pleural effusions is that his glucose is very, very, very low. We sometimes see that in underlying bacterial infections. For example, empyemas can have a very low glucose within the pleural fluid. And so that may make us wonder, oh, is there potentially purulent pericarditis happening within this gentleman's structures? But it's hard to imagine if there was a bacterial infection in that space, things wouldn't have progressed much more quickly. So I think at this point in time, I think we would sort of say, okay, we're going to explore the possibility of a post-viral infection syndrome. We're going to think about the underlying primary myocarditis syndromes like giant cell myocarditis. And then I think at this point in time, certainly start to explore the workup for underlying autoimmune diseases like lupus, RA, and even some of the small vessel vasculitides, while also thinking about some of the seronegative autoimmune diseases like IgG4 disease. I think that sort of is the next direction that we would go. Explore the possible infections, explore the underlying autoimmune diseases, and then think about whether we're going to end up needing an endomyocardial biopsy, because that's often necessary to establish the diagnosis of things like giant cell myocarditis or the other primary myocarditis syndromes.
Awesome. Yeah, so they sent off a bunch of those labs. I'll read them out and then I'll post them in the chat too. So infection-wise, an RVP was negative, HIV negative, Hep B negative, Hep B non-immune, histo negative, quant gold negative, EBV negative, and CMV negative. Blood cultures also showed no growth. Inflammatory-wise, an ESR and CRP were normal, and RF was 14, so mildly elevated, and ANA and anti-double-stranded DNA were negative. And then an SPEP and UPEP showed no evidence of a paraprotein. Ferritin was 822. Iron 33 and TSAT 10, and then his uric acid was 11.1. A CT chest was done showing no nodules, and then the pleural effusions that were previously seen, and a complex pericardial effusion thickening. And a CT abdomen pelvis was done showing short segment circumferential wall thickening and adjacent soft tissue stranding, and subtle soft tissue nodularity, basically for which the differential includes acute inflammatory process enteritis and underlying malignancy cannot be excluded. And then he was started on dobutamine, as you mentioned, due to concern for cardiogenic shock, although his lactate remained at 6 and didn't improve at all. His pressures remained normal, and then he was diuresed with IV Lasix. And that ends aliquot 5. The next aliquot reveals the diagnosis.
Sharmin, I'm not sure if you're here and available. I wanted to turn it over to see if you wanted to chat a little bit. I'm happy to keep going too. I know that there were some tech issues.
Can you guys hear me?
Yeah, I can hear you great.
Sorry. Yeah, sorry. I've been in a it's been a whole ordeal. Sorry to miss most of the case. I think I missed a lot of details, but kind of my understanding of the case is that we're worried about constructive pericarditis. He's in acute heart failure and getting managed for that. So we were working up that hypothesis.
Yes. And then there was I think a CT chest that recently came back that showed some signal for an inflammatory process within the sort of small intestine area.
Got it. And yeah, I heard a part of your amazing discussion, Jack, thinking about the infectious etiology that it seems like, as you mentioned, I also like think about TB. Histo is another one that comes to my mind. And at times, like in endemic area, Whipple's disease can present similarly as well, which seems in this patient we have a lower concern for. You know, at times I often think like infections that can trigger an underlying autoimmune disease. And I think in this person, that's something that I would worry about. But again, like a lot of the workups are negative. The other disease that comes to my mind that is kind of seronegative is like IgG4 disease. And if there's any like hyperplasia or other etiology that can point towards that is something that I would worry about in this case as well. I think in regards to, you know, the thickening, the question becomes like, was there a nidus of an infection there? Is there a malignancy, as you mentioned, with the hypoglycemia, like any neuroendocrine harm diseases that can also have a cardiac manifestation is the other thing that, if I heard correctly, that it was hypoglycemic, is the other one that comes to mind. And, you know, I think like what we're, in terms of like etiology, sometimes, unfortunately, these things tend to become idiopathic, but if there's any other source that we can get additional information, so if there's things that are lighting up within the GI tract, is that amenable to getting tissue from, potentially to augment our workup is another possibility. The other thing that I'm not sure if it was done, sometimes like, you know, cardiac MRI would be helpful in the setting of like getting more additional information about the degree of the involvement too. So yeah, those are my thoughts. Sorry for the incomplete thoughts though. Jack, what do you have to add?
No, I love it. I think I'm so happy that you brought up the possibility of Whipple's disease here, because I think it deserves a role coming into play with the GI finding. We said that probably the most common infection that's going to cause a constrictive pericarditis is TB, but Whipple's and Histo are also two infections that can be on the list. Histo can cause a very aggressive sort of fibrosing and inflammatory mediastinitis that can sometimes hit the pericardium, but it seems like testing for that was negative. And so I think if we say, okay, this is a disease that seems to be aggressively involving the pericardium and the myocardium, and then also maybe involving the GI tract, what types of diseases can do that? I think still with the tempo of disease, and given that the center of gravity of this case was really in the myocardium the whole time, giant cell myocarditis is still at play here. It can cause granulomatous infiltration and inflammation of the heart, and can also have a pretty prominent systemic syndrome associated with it. I don't know off the top of my head whether GI symptoms are a characteristic feature, but I think given that it can have sort of systemic infiltration of a variety of tissues with granulomas, I can't say that the GI involvement definitively falsifies that hypothesis. But I think like you said, Sharmin, certainly Whipple's disease comes into play, but just owing to how rare of a disease it is, it might not be at the top of our list, but it's worth testing for here, given the sort of absence of an alternative diagnosis. And then just thinking through, well, what other diseases can aggressively involve the sort of myopericardium and the GI tract. Lymphoma can also come up and cause a very, I should say, can have a very aggressive course. There are some mucose-associated lymphomas that can start in the GI tract, and then they may disseminate to other structures. And the pericardium is one place where lymphomas can land in the form of malignant pericardial effusions. This seems awfully inflammatory, and I can't say that I've seen constrictive disease from lymphoma, but I don't know that it's. I can't say that it's definitively off the table here, and that uric acid may also be a clue that there's relatively high cell turnover happening, and that can happen in the setting of rapidly proliferative lymphomas overall. And so I think like those would sort of be the diseases at play. And I agree with you, Sharmin. If we can't get a definitive answer from the serum studies for something like lymphoma, for something like Whipple's disease, then giant cell myocarditis, Whipple's disease, and lymphoma all can be diagnosed via tissue sampling. Whether we go for the myocardium or the GI tract is not a decision that I feel like I can make, but one that we could probably make with the specialist. And we may do it in a staged approach, right? We may go for the GI tract first and see if that can give us an answer. And then if it can't, we might do the higher risk biopsy of the myocardium to see if that can reveal a definitive diagnosis. Many of these diseases that we were talking about can present with granulomas, so that may be pose an even bigger challenge if that's what we see on the histopathology. But hopefully there's some other clues that we can get, whether it's staining for Whipple's disease or running some higher level analysis to look for lymphoma as well.
Oh, I totally love that, Jack, and kind of like putting ourselves in their shoes, thinking about like what would be our next diagnostic test. I think a couple of factors to think about is like the stability of the patient and how rapidly this is progressing. So I think like you're absolutely right thinking about the giant cell and thinking about the myocardial biopsy. My understanding that it is a patchy disease, so I wonder if there's any way we can like if MRI in that case would be a good to allow us at least like where to hit or where to be able to go. Because the other thing is like if that comes back negative, is it because we just didn't capture it, or is it truly negative? So that's something that I always wonder with like myocardial biopsies. And then the GI tract, I agree. I think thinking about like, oh, these two are related, I think is a good source to go after as well. But again, I think all of that will be have to put in the context of how sick this patient is and how stable they are in order to be able to undergo a procedure.
Right on. I love that, Sharmin. That's brilliant. Luke, I'm so curious to hear where this case goes from here.
Yeah, no, you guys are amazing. We had the same discussion of like where to biopsy basically, and they ended up deciding to go for the pericardium just because it was the one place they were like, we are 100% sure he has disease here. The GI tract, they were like, we think he has disease, but we're not 100% certain. So he underwent a pericardial biopsy and window with cardiothoracic surgery. And intraoperatively, they said they saw studding of a white, pearly, firm mass-like object between the aorta and SVC, for which the pathology ultimately showed primary pericardial Burkitt's lymphoma. So also something we, like, no one here had ever seen before, but he's currently doing really well, actually. I just checked his chart yesterday, and he's on, like, cycle 3, day 1 of EPOC-R and no longer has constrictive pericarditis, so kind of cool.
Wow, that is amazing. And Luke, did they say like what that pearly structure is? Like, I don't have an association of that as like a characteristic feature of Burkitt lymphoma. Was that just like terrible inflammation that had developed, or was that something that was a key feature of the Burkitt lymphoma?
I think they think just like inflammation from the underlying, like because he had primary pericardial disease, they think that's just how it appeared, but also not totally certain.
Wow, that's amazing. I think, if we break it down like in terms of which of the lymphomas can do this, the aggressive ones being sort of peripheral T-cell lymphoma, Burkitt's lymphoma, and diffuse large B-cell lymphoma. And so of the lymphomas that would do it, it makes sense that it is that one. But wow, what a journey through the case overall. This is absolutely fascinating. Sharmin, what are your thoughts?
My mind is blown, and like you blew my apartment smart because the alarm finally stopped. So I think we're all mind blown. I have never seen lymphoma do this. This is such an educational case. And again, like I think going back to his presentation, like coming in with this kind of like what we figured was like an infection syndrome that probably set it off. But it's kind of fascinating how we can like anchor to kind of like the history of present illness as well, and just the trajectory of how sick he got. And thinking about lymphoma, I think like few people mentioned in the chat, and you were mentioning that. I'm completely mind blown. I've never seen Burkitt lymphoma do this. So thank you so much for
Awesome. Well, Luke, thank you so much for bringing this case. Before we turn it over to Anmolpreet for the teaching points, we'd love to hear if there's other things that you feel like you learned, particularly either about the journey to the diagnosis or the diagnosis itself. Any other pearls that you have to share with us are absolutely welcome.
Yeah, I don't know if I have any pearls, but I think just the lactate also really scared our team to the point that we were discussing, like we ultimately started him on dobutamine just out of fear that alone represented like cardiogenic shock in him, despite being like warm on exam, not having his AKI got better eventually, like after diuresis. And what the attending cardiologist was saying is that basically you can't trust your right heart cath numbers a lot in constrictive pericarditis. And then ultimately, when they started to think it was lymphoma, realized probably this is like a type B lactic acidosis. But I think actually like being able to confidently say that was a lot harder than just thinking it. But yeah.
No, that's so true. The Warburg effect is something that is very often diagnosed either in morning report after the fact or retrospectively after the diagnosis is made. But I think you're absolutely right. Like you have to assume it's hypoperfusion until an alternative diagnosis is made. So it's really interesting pathophysiology in terms of the very high glucose use by the aggressive lymphoma cells. They basically are kind of going through anaerobic metabolism all the time, and so are going to churn out lactate. But I'm with you, my friend. I would have a hard time calling that on rounds on somebody with a cardiac index that low and that degree of pericardial disease.
Yeah, absolutely. Out of curiosity, did anything was for the pleural effusion? Was it sent for cytology? Did anything grew from there?
Yeah, the timing, like the path came back on the pleural effusion the day after the biopsy, and it was consistent with like also Burkitt's lymphoma. So probably could have spared him, but actually he needed a window anyway. So timing wise, he got both.
Yeah, no, absolutely. I think like he definitely with the constructive pericarditis needed the procedure. So, but again, like I think it's again just for the confirmation that you got the right disease. What a case. I have to go back and re-listen to it because I missed portions of it, but this was fantastic, Luke. Thank you so much.
Awesome. All right. Well, Anmolpreet, we'll turn it over to you to take us home with the teaching points on this incredible case today.
Amazing case. Thank you so much, and I loved the discussion. I'm sorry, it's a little the internet connection is a little unstable. So initially we had the patient with the chief complaint of shortness of breath, and then when we think about shortness of breath, Dr. Sharmin taught us that it could be due to hypoxemia, which could involve lungs or the cardiovascular system. It could be due to anemia or generalized weakness due to chronic.
Oh, there we go. Looks like she's back.
I'm sorry.
All good.
So no missed causes of shortness of breath is acute heart failure, cardiogenic shock, tension, pneumothorax, and pulmonary embolism. And if we think about weight gain, it could be due to solid or liquid, and the presence of edema in this patient makes us concerned about water gain. And the lower extremity edema, it could be due to heart causes, liver causes, and kidney causes. So if we think about heart causes, we look for signs of elevated JVP or pulmonary edema. And for the liver causes, we look for ascites. And talking about the congestive heart failure, we say that it progressed over months. And the tempo in this patient makes us think that how the patient is developing the signs of congestive heart failure. Suddenly we think of acute heart failure, and then we think about its causes. And if we think about the common causes of heart failure, we think about the 4 buckets: ischemic cardiomyopathy or non-ischemic, in which we have hypertension, arrhythmia, valvular heart disease. Talking about the hyperacute heart failure, it raises concerns for myocarditis. And if we talk about that the patient also received diltiazem, which is a non-dihydropyridine calcium channel blocker, and it basically reduces calcium influx in the myocardium. That's how it works. And calcium channel blockers like diltiazem and verapamil basically affects the ejection fraction, and they therefore are contraindicated in a heart failure with reduced ejection fraction. Then we saw that the patient had elevated troponin, which could be due to myocarditis and ischemia again. So in this patient, a myocarditis post-viral illness seems a lot likely. And then this patient, we just wanted to assess that how severe the CHF exacerbation was there. So we saw that the patient was like compensating with the sympathetic tone. He had sinus tachycardia and narrow pulse pressure, which raised concerns for impending cardiogenic shock, which was also proved by the evidence of increased lactate and pre-renal AKI in the labs. And most CHF exacerbations, they are not inflammatory, but we are seeing an inflammatory fingerprint in this patient by the evidence of leukocytosis and presence of systemic inflammatory signs. Therefore, it reinforces the idea of myopericarditis secondary to recent illness like COVID, upper respiratory tract infection, atypical GI organisms, or could be eosinophilic myocarditis as well. So ultimately, we came over to the problem representation of an exudative pleural effusion with mildly reduced ejection fraction with constrictive pathology with a new onset heart failure. And the constrictive pericarditis basically is a fibrous tissue is there which stiffens and forms scars, leading to constriction of that constriction formation in the pericardium, and that can lead to shortness of breath. And how can we divide the causes of constrictive pericarditis? It could be due to non-inflammatory or inflammatory causes. And in this patient, we see that we have the inflammatory fingerprint. So what are the differentials for that? It could be infections like TB pericarditis, and histo or Whipple's disease. Then it could be cancer, which can be carcinoid syndrome, or autoimmune diseases, which can be divided into seropositive and seronegative. Seropositive being lupus, RA, EGPA, and seronegative being IgG4 disease. So to evaluate the patient, we need to send out serologies for all of that things, and to check what is causing basically this patient's inflammatory constrictive pericarditis. So then we saw that this patient had myocarditis that we knew, but with GIT involvement. So what could be that causes? It could be infiltrative disorders with granulomas like giant cell myocarditis. It could systemically infiltrate so many organs. And then there could be lymphoma, which is evidenced by the high LDH and high uric acid in the labs. And so we were thinking how to diagnose this patient. We were thinking about to biopsy one of the locations. Either it could be GIT or it could be the pericardium or myocardium. So basically, ultimately, the diagnosis was made by the biopsy only, as CP solvers say that tissue is the issue. So, so the biopsy, which it showed Burkitt's lymphoma. That is an aggressive non-Hodgkin B-cell lymphoma, and this patient it had primary pericardial Burkitt's lymphoma. And so I learned a lot from the case. Thank you so much for presenting, and I have got a lot to learn. Thanks a lot.
Whew, you're going to set off the fire alarm in Sharmin's apartment again with those teaching points.
Please
that was
don't.
absolutely fantastic.
That was fantastic.
All right.
Thanks,
everybody. Thanks everyone for joining today. Everyone have a great rest of your afternoon, evening, or whatever time of the day it is. Great to see y'all. Take care.
Thanks all.